Hi everyone, my name is Dr. Yasser Osman and I'm going to talk about epidural anesthesia in this lecture. Epidural anesthesia is central neural block obtained by injecting local anesthetic solution in the epidural space, which is the extradural area, where spinal nerve root passes. This picture can demonstrate the difference between the spinal anesthesia and the epidural anesthesia. This is the extradural or the epidural space, and this is the subarachnoid area that the spinal needle reach to give spinal anesthesia. What is epidural space? Epidural space is a potential space between the dura mater in this red line and the ligamentum flavum here. This is the epidural space. Technique of epidural anesthesia. The most popular method to locate the epidural space is the loss of resistance technique. The epidural needle is inserted through the skin and advanced in the midline till the spinal ligament are entered. Then the stylet is removed and an air or saline filled syringe with freely mobile plunger is attached to it. If the needle tip is in the spinal ligament, it is difficult to inject the syringe. The needle is advanced very slowly and the plunger is pressed. As soon as the needle pierces the ligamentum flavum and enters the epidural space, there is no further resistance to the plunger. For short procedure, a single dose of local anesthetic is sufficient, but this is not the common use of the epidural. The common use is for the longer operation and if post-operative analgesia is required. A catheter is inserted via the needle into the epidural space and used for continuous epidural analgesia. This picture shows the doctor putting the catheter in the epidural needle. What is the epidural needle? The standard needle used for the epidural anesthesia is called Towhee needle. It is a large needle, 18 gauge. It allows a catheter to pass through it easily. It has a curved blunt tip that helps to avoid dural puncture and allow for the direction of the catheter. Some have wings at the hub of the needle for great user control. As we can see in picture 1, this is the curved tip, and the idea of the curved tip is to make puncturing the dura more difficult. And this is the diagram of the epidural needle or Towhee needle, showing the difference between the tip, the curved tip, and the straight one of the spinal anesthesia. It has 1 centimeter graduation in its shaft, as we can see in this picture. And this picture shows that the catheter inside the needle is guided by the curved tip to the direction that we want to thread our catheter in. What about the epidural kit? It consists of the epidural needle that we talked about, the catheter, and the syringe with a free plunger that we talked about. These wings that may be attached to the end of the epidural needle, as here, for easy control. And this is called a bacterial filter, just to help to attach the end of the catheter after we perform the epidural anesthesia. Drugs. Drugs used: first, xylocaine. Concentration is 1.5 to 2% solution. Dose 15 to 30 milli, onset of action from 10 to 15 minutes, and the duration is about 1.5 hours, while bupivacaine concentration is 0.5%, dose 15 to 25 ml, onset of action 15 to 20 minutes, and duration from 3 to 5 hours. Epinephrine can be used with both drugs to increase the efficiency and the duration of the drugs. Indications. Surgical indications are the same for spinal anesthesia, but it can be used also for operation at higher levels because we can perform what is called thoracic epidural. Relief of acute pain, for example, labor pains, and this is very famous, post-operative pain, relief of chronic pain, and relief of post-dural puncture headache by epidural blood patch that we talked about in the previous lecture. The onset of epidural anesthesia is much delayed compared to spinal anesthesia. The intensity of the epidural anesthesia, sensory and motor block, is much weaker when compared to spinal anesthesia. The epidural anesthesia is more difficult as a technique than spinal anesthesia because the endpoint depends on observation of the change in the resistance to pressure, whereas in spinal anesthesia the endpoint is the clear fluid, i.e. the CSF at the hub of the needle. The contraindications is the same as that of spinal anesthesia, divided into absolute and relative. The absolute contraindication is patient refusal, patient on anticoagulant, local and systemic sepsis, uncontrolled hypovolemia, severe fixed cardiac output state, definite allergy to drugs, and absence of resuscitation equipment, while relative is neurological disease and deformity of the vertebral column, cardiac disease, and elevated intracranial pressure. Complications of epidural anesthesia. The complications are similar to those following spinal anesthesia, but the risk of systemic local toxicity is higher due to the large volume injected of the local anesthetic. Accidental injection of a big volume of local anesthetic into the subarachnoid space lead to higher incidence of total spinal block. Accidental dural puncture lead to very high incidence of headache, which is the post-dural puncture headache. Intravascular injection of local anesthesia lead to systemic toxicity. Backache is more common as the needle is bigger in size. What about another category which is called combined spinal epidural anesthesia? This technique combines the rapid onset and the dense block of spinal anesthesia with the advantage offered by using epidural catheter. How can we use that? By advancing the epidural catheter into the epidural space. When we do that, we remove the stylet and insert the epidural catheter, and also we insert a smaller 27 gauge needle that pierces the dura and inject the spinal anesthesia, the local spinal anesthesia in the subarachnoid space. Thank you.